Please, everyone should support with the time because we don't have time enough. We have
Good morning,
time for
everybody.
discussion later on, please. Go on.
Good morning, everybody. I'm going to talk today about the anteromedial rotatory knee instability. I'd like to present our new reconstruction technique and our early preliminary results. Let me start by this examination under anesthesia in our operating room. This patient had a positive Lachman test, positive stress valgus test, and 30 degrees of flexion. He also had a positive dial test at 30 degrees of flexion with an obvious anterior subluxation of the medial tibial plateau. This complex pattern of stability is usually caused by deficiency of both the anterior cruciate ligament and the medial collateral ligaments, resulting in shifting the center of knee rotation laterally with excessive anterior tibial translation and external rotation. In 1968, Slocum and Larson were the first to describe this complex pattern of instability. They stated that this anteromedial rotatory instability was caused mainly by anterior cruciate ligament and deep MCL disruption. They stated that the basic lesion which is present in all these patients allowing excessive external rotation was the deep MCL injury. This concept was fairly common for a long period of time until this biomechanical study from the Pratt group came out that magnified the role of the posterior oblique ligament, overshadowed the role of the deep MCL. And he stated that for normalizing the native knee kinematics, a posterior oblique ligament and superficial MCL reconstruction in a double strand fashion should be done. This concept was later enforced by another biomechanical study from the Danish group, Martin Lind and colleagues, who made a small modification of the previous technique using a single femoral insertion point, making the reconstruction a triangular-shaped reconstruction. He stated that the management of the anteromedial instability should involve reconstruction that address both the superficial MCL and the POL, and this is the only way to restore native knee kinematics. Recently, the same Danish group published a one-year follow-up of around 600 patients that received this reconstruction technique. They doubted their own reconstruction, the efficiency of their own reconstruction technique, where they stated that the valgus stability was restored in 2/3 of the patient, but this patient had a lower Kuss and Tegner activity scale. They concluded that this may be due to not taking in account the deep portion of the ligament during surgical reconstruction. Owing to this wonderful work done by the Imperial College in London, the role of the deep MCL was re-highlighted once again. You could see in this cadaveric dissection the orientation of the deep MCL, where it fans distally and anteriorly from a point just distal and proximal to the superficial MCL insert in a broad tibial attachment, thus oriented perfectly to resist the external rotation. This study was followed by another study that tested the length change pattern of both the medial collateral ligament and the posterior oblique ligaments. It showed that the deep MCL lengthens and tightens in external rotation, while the posterior oblique ligament slackens just immediately when the knee is flexed from an extended position, making it a bad candidate to restrain the external rotation. This is a nice cadaveric dissection in motion done by the Christian Fink group in Austria that shows that the deep MCL tightens in external rotation, thus acting as a primary restraint to tibial rotation in the absence of the superficial MCL. These dissection studies were followed by biomechanical studies that also concluded the same results, that the deep MCL was the largest medial restraint to tibial external rotation. How about the reconstruction techniques? This biomechanical study showed that the only way to restore the normal native kinematics in the anteromedial rotatory instability was adding an anteromedial reconstruction band that mimics the role of the deep MCL. And by adding this band together with the superficial MCL, normal native knee kinematics could be restored from 0 to 100 degrees of flexion, particularly anterior tibial translation and external rotation. Another biomechanical study followed showed that not only by adding the anteromedial band, but also by making the superficial MCL reconstruction flatter in shape, this could also help in restoring knee kinematics. Based on the previous data, we described our technique in reconstructing both the superficial and deep MCL components using a single peroneus autograft, which was recently published in Arthroscopy Techniques. Why peroneus longus? We prefer to use the peroneus longus in the MCL reconstruction due to its flat proximal end, which mimics the native ligament. And this is a small video for our technique. We start by marking the medial epicondyle, followed by a guide pin which is placed slightly distal and posterior to the medial epicondyle at the deep MCL femoral insertion point. This guide pin is drilled with a reamer to the desired depth and length, forming a socket for the deep MCL femoral insertion. A shuttering suture is placed for later graft passage. Now we are directed distally to create the broad attachment of the deep MCL on the tibia, just 1 centimeter distal to the joint line. We make 2 conversion tunnels about 20 millimeter apart. Care must be taken not to blow out the medial cortex. Then a passing suture is placed in the transosseous tunnel in order to pass the graft later. Now we start with the passage of the graft. The distal end of the peroneus longus graft is dogged first in the femoral socket, fixed by an interference screw. The free end is passed in the transosseous tunnel from posterior to anterior, thus creating the broad attachment of the deep MCL. Then the free end of the graft is brought back proximally, fixed at the medial epicondyle in a neutral rotation, slide varus force being applied, and 30 degrees of flexion. The free end of the graft is brought distally to a 0.6 centimeter distal to the joint line to create the tibial attachment of the superficial MCL. And here comes the beauty of the peroneus longus. You could see how flat is it and closer to the native MCL. This point is reamed to the desired diameter and depth. And the graft is passed through the tunnel. Cycled multiple times and then fixed with an interference screw, a 30 degrees of flexion, neutral rotation, and also slide varus force being applied. And this is the final shape of our construct. Until now, this is an unpublished data. Until now, we did 7 cases. We followed up these cases using a valgus stress radiograph, an external rotation angle measurement at 3 and 9 months. We are experiencing excellent control of the external rotation, significant reduction in the medial joint line opening. Only 2 cases required manipulation under anesthesia at 3 months. The only drawback of this technique that we need a fairly long graft, about 25 millimeter, to reconstruct both components using a single graft. In summary, the deep MCL walls and still the basic lesion for anteromedial rotatory knee instability, external rotation as well as valgus stability could be restored to nearly normal values when deep MCL is reconstructed. The peroneus longus graft provides a flat graft that mimics the native MCL. Thank you for your attention.